In this video, we're going to continue our introduction to spinal manipulations by asking this question. Why would you want to learn to perform these spinal manipulations in the first place? So I think back to when I was a student physical therapist going through my clinical rotations, and I encountered a lot of practitioners who were either skeptical of spinal manipulations or maybe they didn't think they worked at all. Of course, there were definitely practitioners who used spinal manipulations in their practice. What does the evidence say about spinal manipulations? So the evidence comes from a variety of studies that looked at a variety of manipulation techniques on a variety of different conditions and outcome measures, etc. And especially in the Journal of Physical Therapy, you'll see these papers that have some kind of graph or data that looks like this. And I'm not citing a specific paper here, but they generally all have results that look like this. So there's one treatment group here that received exclusively therapeutic exercises that could include strengthening, stretching, etc. And then there's another group that received only manual therapy. Now that manual therapy includes manipulations, but it includes other things like just mobilizations that we talked about in the previous video. It could be soft tissue massage, deep tissue massage, anything in the manual therapy scope. And then there's a combined treatment group that received both manual therapy, including manipulations, and therapeutic exercises. And then for all three of these treatment groups, they use some sort of outcome measure to determine the effectiveness of the treatment. And for this arbitrary outcome measure here, a lower score is poor and a higher score is good or better. And note that for some outcome measures, it's the reverse. A lower score is actually better and a higher score is worse. You just have to look at the exact outcome measure used in the study. And generally speaking, what the vast majority of these studies find is that the group that receives therapeutic exercise only gets improvement. The group that receives manual therapy only also gets improvement. But when you combine therapeutic exercise and manual therapy, including those manipulations, it sort of has an additive effect where the combination of these two treatment modalities is greater in effectiveness than therapeutic exercise alone or manual therapy alone. So let's think about that in context. So let's say you have a patient that has excessive thoracic kyphosis, so they're limited in thoracic extension. Well, one manipulation technique that theoretically could work would be the prone thoracic extension manipulation or closing manipulation. And if you go in there and you do that manipulation and that's all you do, well, in the short term, so like minutes to hours, they probably will gain about 5 degrees of thoracic extension at the level you're manipulating. But I guarantee you, once that day is over, they go to sleep, they go back to their chronic posturing that probably led to that in the first place, they're going to be right back where they started before you manipulated. You can have them come in day after day after day. You're probably going to see very little changes. However, if you perform that prone thoracic extension manipulation, but then combine it with some kind of exercise in the clinic and exercise at home that you send them with, where they're practicing moving into thoracic extension, they are much more likely to keep that thoracic extension and you'll see greater effect over time. And so obviously the manipulation would be the manual therapy. The thoracic extension exercises, like a seated extension mobilization on a chair, that would be the therapeutic exercise. So bottom line, TheraX plus manual therapy is better than either of these things in isolation. Here's a great example of a study that looked at the effect of spinal manipulation on mechanical neck pain. And the way that they quantified mechanical neck pain on the y-axis here is through the NDI, the Neck Disability Index. And this is one of those outcome measures where a lower score is actually better. A lower score means less disability. A higher score means more disability. That's worse. So you want the score to be lower on the NDI. And they tracked these 4 groups from baseline to 1 week to 4 weeks to 6 months. Now if we look at these two right here, the green square and then kind of behind it is this black triangle, these are your exercise-only groups. The triangle, they were positive on the clinical prediction rule for manipulation. and the green square was negative on that clinical prediction rule. And what you see is that both these groups at 6 months, at 4 weeks, and especially at 1 week, they have higher NDI scores. And these other two groups right here, the blue diamond and the pink square, these are manipulation plus exercise groups. Notice it doesn't say manual therapy. It's specifically manipulation. So again, depending on the result here, that would give us more power to talk about the manipulation aspect than just manual therapy in general. But again, what you see here, especially at the 6-month mark, is that both of these groups, regardless of whether they were positive or negative on the clinical prediction rule, they have lower NDI scores than those that received exercise only. And so kind of what you're seeing here is that when you perform spinal manipulations in conjunction with therapeutic exercise, there tends to be better outcomes. And especially here, if you look at the manipulation plus exercise group, which were positive on the clinical prediction rule, you've already got a substantial improvement compared to the other groups, even at just 1 week. So very powerful. The second factor here is patient buy-in. When a patient buys into your treatment approach and your plan of care, they're much more likely to have better outcomes. So suppose you have a patient that has a previous positive experience with chiropractic and or PTs who perform spinal manipulations. So I practice in the state of Oregon, and I can't say for every area of the country, but it's pretty common up here for people to be concurrently seeing an acupuncturist or concurrently seeing a chiropractor, or sometimes both, or they've seen them in the past. And a lot of these people will say, you know what, I had a cervical manipulation there and it really helped with my neck pain. And it really helped me kind of get that extra mobility in my neck. Well, if you look at the clinical prediction rule for a cervical manipulation, one of the criteria is patient believes it will work. If the patient believes it'll work, it makes it more likely that they will have reduced neck pain and increased cervical range of motion. So if your patient likes manipulations, they've helped in the past, you are much more likely to have better outcomes with them if you can also do those manipulations, which will help the patient buy into your treatment approach. And again, you want to make sure, first of all, that the manipulation is indicated in the first place, and also that it's not contraindicated and that it's safe. But getting patient buy-in generally results in better outcomes. And the last thing here is opportunities, more specifically opportunities outside of the clinic. I am never going to suggest that you cannot be a successful practitioner and have great outcomes with your patients if you do not perform spinal manipulations. You can certainly be a great therapist. However, some clinics, schools, and other similar institutions, particularly around the area of teaching, may desire physical therapists that have the ability to perform spinal manipulations. So even if you didn't use them regularly in practice, you might be more likely to get a teaching opportunity if you have that in your skill set. Thank you for all your support. Be sure to check out my Instagram for cool science and not science stuff.